and good afternoon, colleagues. I'm going to speak about lessons beyond atrial fibrillation with a focus on obesity. Here are my disclosures. First of all, with stroke prevention and atrial fibrillation, I'm going to ask us to consider obesity as a risk factor beyond the CHADS-VASc score. And I will speak also about obesity's global burden of disease. I'll make the point that diet and exercise can reduce atrial fibrillation symptoms and severity, as well as waist circumference and body mass index. Then I'll step back from the cardiovascular illness of stroke to include venous thromboembolism and myocardial infarction to make the point that these three cardiovascular killers share common risk factors such as obesity. And I'll wrap up by showing that GARFIELD-AF will improve our understanding of the obesity-atrial fibrillation connection. This is a real patient of mine that I've followed annually for more than a decade in my office, and he has the triple, very common cardiovascular problems of hypertension, hyperlipidemia, and obesity. This 76-year-old man awakens with garbled speech in the middle of the night, spouting nonsense words and confused. His arousal wakes up his wife. She quickly realizes something is terribly wrong, and she summons emergency medical services. When the ambulance personnel arrive, his blood pressure is 185/82. His heart rate, which year after year had been normal sinus rhythm at a well-controlled rate, is 129 beats per minute and irregularly irregular, and his body mass index calculates at 38 kilograms per meter squared. I'll remind you that the official definition of obesity is a BMI of 30 or greater. On his neurological exam, he is unable to name months, to name a pen, to name a watch, or to follow a simple command such as showing his thumb. Here is the first electrocardiogram obtained. It shows atrial fibrillation, atrial flutter with a rapid ventricular response. We did emergency magnetic resonance imaging. It's easier to explain the imaging if I start with the right side, the normal side, and you see here that the M2 branch of the middle cerebral artery is completely open, patent, and normal. In contrast, the left side, the M2 branch of the middle cerebral artery is completely cut off because he has had a thrombus travel from the left atrium to the MCA, causing this symptomatically devastating stroke. Let's step back now to the global burden of obesity. It accounts for at least 3.4 million deaths per year, and for at least 4% of years of life lost. Physical inactivity and carbohydrate-heavy eating patterns are considered causal. The rise in obesity rates is actually soaring in economically developing countries, but the rise is slowing down and plateauing in developed countries economically. Sadly, the prevalence is increasing in children as well as in adults. Here we have the results from a global survey published several months ago in The Lancet. If we look overall, we see that 38% of men and women around the world are classified as overweight, overweight being a BMI greater than 25. Let's look at countries that are undergoing economic development, the less developed countries, and we see in these less developed countries that women are more overweight than men, and notice that there's an upward slope. In contrast, in the developed countries, the men are more overweight than the women, and the slope has really flattened out for both men and women. How are we going to approach the problem of obesity? Well, certainly there are some designer drugs that have been approved and licensed for use, but they have various cardiovascular side effects. They're expensive. They can help with weight loss with 3 to 8% of body weight, but it's not really a very practical approach to conquering and managing a global public health care problem. What about intensive diet and exercise? Could this have a role? Well, if we look at a study published in JAMA in obese patients with atrial fibrillation, first of all, we see that with proper coaching and education of patients in an intervention group shown in the round filled-in circles, that in fact we can get a dramatic reduction in the waist circumference, and this is accompanied by a dramatic reduction in the BMI. The body mass index can actually decrease by about 6 units compared with a control group. Now, does this impact patients with atrial fibrillation who are obese, such as my patient that I presented to you? Well, in this study, it certainly did. These patients in the intervention group getting diet, exercise, and weight loss have a marked decrease in their symptom burden score of atrial fibrillation, and they have a marked decrease in their symptom severity score from atrial fibrillation. Obesity has a multitude of adverse effects on the cardiovascular system, and I'm only highlighting a few of them. Hypertension, obstructive sleep apnea, worsening of coronary disease and microvascular ischemia, the release of inflammatory cytokines, which causes a host of other problems, and of course, altered electrical function leading to a propensity to atrial fibrillation. So we shouldn't be thinking of these various cardiovascular problems and risk factors as separate. They overlap, as shown in this Venn diagram. Obesity overlaps not only with AF, but also with myocardial infarction, diabetes, hypertension, and obstructive sleep apnea. And we see right here some risk factors in the CHADS-VAS score, coronary disease, diabetes, and hypertension overlapping with atrial fibrillation. So all these various cardiovascular problems start to merge. Similarly, venous thromboembolism and atherosclerosis in the form of stroke and myocardial infarction also have shared risk factors and a shared pathophysiology of inflammation, hypercoagulability, and endothelial injury. It can lead to pulmonary embolism, or it can lead to myocardial infarction or stroke, and many patients with pulmonary embolism will be at much higher lifetime risk of developing MI or stroke, and patients with MI or stroke will be at much higher lifetime risk of developing pulmonary embolism. So one lesson is that we should consider, due to these common risk factors and common pathophysiology, not to split these major illnesses apart, stroke, MI, and pulmonary embolism. We should be lumping them together also in a Venn diagram. Now, GARFIELD-AF, in the first 22,000 plus patients enrolled, carefully maps out the body mass index. And you see that we have enrolled many patients in GARFIELD-AF who are obese with a BMI greater than 30. So the take-home messages are that obesity is a risk factor for developing atrial fibrillation, and also obesity has a contribution to causing venous thromboembolism and myocardial infarction. Obesity may be a risk factor for stroke in patients with established atrial fibrillation. AF patients should embrace a heart-healthy lifestyle with the goal of achieving a BMI less than 25 to decrease their symptom burden and severity of AF. And finally, GARFIELD-AF is going to enlighten the obesity-stroke relationship because we have such a large sample size, adequate power, and a pertinent case report form. Thank you very much.